Welcome to Module 9, Newborn at Risk, Part 2. Here are our chapters for this module. We're going to be covering chapters 23 and 24. Please pause here to review the learning objectives for this module. Okay, so as you've already learned in earlier lectures, pregnancy duration is calculated from the first day of the patient's last menstrual period, or also referred to as their LMP. And it lasts for about 280 days or 40 weeks. So really, why is this important for us to understand? Knowing someone's gestational age will help ensure that we give the best and most effective care during their labor and after their birth. Many risk factors after birth stem from how developed the baby is in utero, in addition to how well the placenta has been functioning. So let's go ahead and review the different terms of pregnancy for your reference. So we have anything before 37 weeks is generally called preterm, but preterm is defined even more narrow because some babies that you will take care of in a normal postpartum unit may be late preterm because they're near term and their lungs are developed and they're functioning well, but maybe they're having some feeding issues or stuff like that, but they're able to handle that in a normal postpartum. So 34 to 36 weeks, 6 days is considered that late preterm or near term. Before 34 weeks, those babies tend to go to NICU. Then you have early term, so 37 weeks to 38 weeks and 6 days. Full term, which is obviously our goal, 39 weeks to 40 weeks, 6 days. You have late term, 41 weeks to 41 weeks, 6 days. That is where you would expect somebody to be induced if they haven't already had a baby. And then post-term would be anything over 42 weeks. And that is not our goal at all. We would like everybody to be delivered before 42 weeks. Because having a baby that is post-term can be just as high risk as having a baby that's preterm. Post-term newborns only account for 5.5% of births, but these babies are extremely high risk for stillbirth. So why is that the case? It's because the placenta is actually a temporary organ. After 42 weeks, fibrin deposits, calcium deposits, hemorrhagic infarcts can occur, and that impedes the ability of the placenta to nourish the fetus. So it doesn't allow the blood to flow freely between mom and baby. So oxygen levels decrease, blood flow in general just decreases. So this is why you're going to see patients to be counseled to have their babies around 40 weeks because it actually will improve maternal and fetal outcomes. So there are many things that can impact the health of a newborn. One of the areas that has potential to impact all babies is how well they grow in utero. So how a fetus grows is directly linked to the mother's nutrition, their genetics, how their placenta is functioning throughout their entire pregnancy, the environment that they live in, medications that they're taking even from conception, any drugs that have been consumed, alcohol, and obviously many more things can affect pregnancy and growth. Before birth, pregnant patients get ultrasounds to measure growth of the baby and determine if the fetus is on track with the expected size at the various gestational ages. But true measurements are unknown until birth. Ultrasounds have a margin for error, so while it's helpful, it's not always completely accurate. So here is how a baby is categorized at birth. We have SGA, or small for gestational age. This is when a baby's weight is going to plot less than 10th percentile at the gestational age that they are born. AGA, or appropriate for gestational age, is the group we would consider normal size because they fall between 10 and 90% on the growth chart. This is the goal range because these babies have the lowest risk for morbidity and mortality. And then finally, our last category is LGA, or large for gestational age. And these babies are born above 90th percentile for the gestational age that they are born. So you can kind of see this picture on here, a small baby, an average baby, and a very large baby. SGA deliveries account for 8 to 10% of all of our deliveries, and LGA accounts for 10%. Newborns in these two categories are automatically higher risk for complications during labor, during their birth, and in the first month following their delivery. So that's why we have to be aware of what their gestational age is and try to have accurate dates, because we want to know if they're falling below that 10th percentile or above that 90th percentile, because it triggers us to screen things more closely. So here's an example of a growth chart from the CDC. We do track based on gender because normal growth is actually different between male and female due to genetic and hormonal differences. We track weight, we track length, and head circumference at each appointment to ensure that the baby is growing proportionately and not falling off the growth curve. At birth, this is where we can see what percentage the baby is based on their gestational age and their birth weight. For example, if you have a 39-week delivery of a baby that is 6 pounds, it would actually be below the 10th percentile. And a baby that was 39 weeks and 9 pounds would be greater than the 90th percentile. So at delivery, we enter the weight in the computer system. Both Kaiser and Loma Linda use Epic, and it calculates the baby's percentile based on their gestational age and the weight that you put in grams. And then we use that percentile to perform different assessments depending on where they fall on that growth curve. Okay, so let's look a little closer at small for gestational age. SGA is a general state to describe a baby that is less than 10 percentile, but what causes the size of this baby to be small is wide-ranging. It could simply be genetic predisposition. If the parents are small people, we would not expect them to be having a giant baby. It would be appropriate for that baby to be quote-unquote small. Additional causes could be maternal factors like poor nutrition, substance abuse, hypertension, diabetes, and even anemia. But there can also be fetal factors that affect their growth. Maybe there's twins. Maybe it's a triplet, quadruplet pregnancy. Anything that has less space for them to grow is going to prevent them from being giant babies. Genetic conditions like Down syndrome automatically make babies smaller. Congenital anomalies like cardiac conditions, or a chronic fetal infection, like if mom has syphilis that's across the placenta, or rubella infection that's across the placenta, all of those can impact the growth of the fetus. Lastly, the placenta. We talked about how it's a temporary organ, and now it has to provide nourishment for that baby. And we can have issues with the placenta, like an abruption, where it starts to peel off the side of the uterus, so it decreases the amount of blood flow that can go through. Placenta previa, placenta insufficiency, so maybe there's already calcifications happening. There could be an abnormal cord insertion, so it's not flowing as freely as expected. There can even be an infarct on the placenta where it adheres to the wall, and it's not going to flow during that portion. With that being said, so many things can affect the baby's growth. If it's determined on ultrasound that the baby is measuring small and there is known risk factors beyond genetic predisposition, the doctor may recommend the patient is induced and delivered at 37 weeks. If the baby is not growing and thriving, we call that fetal growth restriction, FGR, or you may commonly hear it on the unit as IUGR, which is intrauterine growth restriction. They just kind of have changed the terminology recently. Think of this as the environment in the uterus is not going to sustain the baby for very long. It becomes hostile, and this is extremely high risk for a stillborn baby. Okay, so what classifies a baby as FGR or IUGR? A birth weight that is below 3rd percentile, or all their measurements are less than 10th percentile with a maternal condition. So maybe mom has high blood pressure or diabetes, and then the baby's measurements are all really low. That would mean that her disease process is preventing the baby from growing. 30% of SGA newborns are IUGR, and there's a really high risk of morbidity and mortality for these babies. Now, SGA can be broken down even further, and here are some weight ranges and their classification. So we have low birth weight infants may be able to, low birth weight infants may still be able to stay with their moms in postpartum, like I kind of talked about. So kind of the cutoff is around 5.5 pounds. Anything 5 pounds or less, they're probably going to go to the NICU. But anything less than 5 pounds, we won't even consider having them with their mom. And they're definitely going to have to go to the NICU. So these babies are going to have difficulty with feeding, difficulty with temperature regulation, and their blood sugars. So they're going to need medical assistance to ensure that they're healthy and growing. So as you can see over here, those low birth weight infants, less than 2,500 grams or 5.5 pounds, those babies you may see in postpartum with their mom, because our goal is to keep them with mom as long as they're stable. Then you have the very low birth weight and the extremely low birth weight. Those will all be in NICU. I discussed earlier that the nurse will have different assessments based on the weight percentage at birth. So when a baby is small, they often have difficulty transitioning from intrauterine to extrauterine life. They tend to be needing some resuscitation at the warmer with our NRP. If it's known that the baby is going to be small, a lot of times we have the NICU team present to attend their delivery and help with any kind of issues with transitioning. These SGA babies are going to need blood sugar monitoring per whatever policy that the hospital has. At Kaiser, for instance, we check within 90 minutes of delivery, and then at 4 hours of life, 8 hours of life, 12 hours of life, 18 hours of life, and 24 hours of life. This is to make sure that the baby is latching properly, transferring the milk, and then metabolizing well. Small babies struggle to regulate their temperature because they lack brown fat that insulates better. So we can increase the temperature of the room and environment around them and keep babies skin to skin. Ensure they have their hat on, and then educate the parents to keep babies covered. We want to really try to prevent any cold stress. And really often I'll walk into a room and the baby is no hat on, completely open, and the vent is blowing directly at mom and baby. So making sure that we remind them that baby can get cold really quickly. So while they're in the hospital, keeping that hat on, keeping them at least skin to skin or swaddled. SGA babies need to feed early and often. This is going to help them to regulate their blood sugar and also essential to getting the mother's milk to come in sooner. More milk will help this baby grow and get stronger faster. Depending on the size of the baby, sucking and swallowing reflexes may be sluggish or not even there. These are the babies that may end up in the NICU. This size baby having a low threshold for admission to the NICU is really important to be aware of. So they need really close assessment so that you know if they are needing admission sooner rather than later. If the baby is sucking and swallowing but not taking in enough to regulate their blood sugar, that's when the nurse can administer supplementation with formula or even oral glucose gel, depending on the state of the baby. And then once you do the oral glucose gel, you latch the baby to the breast right away. So it helps them get kind of a quick shot of sugar and get their blood sugar up. And then our goal is to get them latched to get whatever milk transfer they can get to keep them full. Finally, the nurse is going to do some daily weights to ensure the baby is on a safe path post-delivery. These babies don't have much weight to lose, and they need strong nursing management to keep them healthy and safe to go home with their families. All right, let's look at the other end of the spectrum, large for gestational age or LGA. These babies are just at risk as small babies. The cause of an LGA baby can be genetic. Large parents will likely have a large baby. For example, Shaquille O'Neal is genetically a very large man. We would not expect his baby to come out 6 pounds or less than 10th percentile. Additionally, if the patient was a large baby themselves, if they've had other large babies or there's any genetic syndromes that can be linked to an LGA baby, we would expect to see those greater than 90th percentile. Now, the other reason for an LGA baby could be maternal risk factors. Is the patient diabetic, type 1, type 2, gestational, especially if it's not well controlled during pregnancy or at conception? We're going to talk about that in a future lecture about DM and pregnancy, but it is directly linked to larger babies at birth. More sugar going to the baby is going to result in that baby growing significantly bigger. So you may have heard of the term macrosomia before. What does it actually mean? So macrosomia is a baby that is born weighing over 4,000 grams or 8 pounds, 8 ounces, no matter what their gestational age is. So if they're 41 weeks and over 4,000 grams, if they're 37 weeks and over 4,000 grams, no matter the gestational age, anything 4,000 or greater is macrosomia. It occurs in 7% of births, and then even larger babies, 1% are weighing over 4,500 grams, which is 9 pounds, 9 ounces. I am not a short person, and neither is my husband, and both of our girls were considered macrosomia. My oldest, it was 8 pounds, 12 ounces, and my baby was 8 pounds, 9 ounces. So technically both of them were macrosomic. So why is having a LGA baby worrisome for delivery and after? A large baby can cause major complications for the mother. She has to get this baby simply out of her pelvis. And a large baby can make labor extremely difficult and oftentimes leads to them needing a C-section if the baby won't descend and rotate to dilate the cervix. And often we call that failure to progress. So maybe baby just cannot pass through the pelvic inlet. And to dilate the cervix, the baby's head has to put pressure on that cervix. So unless it can do that, they end up in a C-section. If the patient is able to deliver vaginally or there's no major complications, a large baby can increase perineal lacerations. So oftentimes a 3rd or 4th degree laceration can go along with an LGA baby. They are most common complications with a large baby at delivery. most common complication for a mom with a large baby at delivery is a postpartum hemorrhage, because that uterus gets extremely stretched out, and maybe paired with a difficult labor, it can cause complications with that uterus contracting down after birth. So this is going to cause that increased bleeding. Just think of a balloon that gets overly stretched. When you let the air out, it never looks the same again. Well, our uterus is like that. So if it gets really stretched out, or it's been a really long labor, and that uterus is a muscle, it gets real tired. So then next thing you know, you're having more bleeding. Also, trauma from the delivery can contribute to an increased hemorrhage risk. So if they have that 3rd or 4th degree laceration, that will definitely increase the bleeding and hemorrhage risk. LGA or macrosomia also causes major issues for the baby. Have you ever heard of a baby getting stuck during delivery? A large baby can have what we call a shoulder or body dystocia, where it gets stuck in the mother's pelvis during delivery. This is considered a medical emergency. It may lead to birth injuries, like the baby getting a broken clavicle, if you've ever heard of brachial plexus injuries, and even asphyxiation. If the baby does come out without any complications, LGA babies do struggle with respiratory distress, hypoglycemia, and polycythemia. If you ask any nurse, they'll have their thing that they absolutely hate to have occur during their shift. And I would say that shoulder dystocia is probably my number one thing that I absolutely hate. It is, I'll do a hemorrhage any day. I'll do many other emergencies without really worrying about it. But a shoulder dystocia is probably one of the scariest things that can happen in labor and delivery. So let's move on to some nursing management. So just like an SGA baby, LGA babies are going to require the nurse to manage them more closely and ensure they are safe. These babies that are greater than 90th percentile will also be checked for hypoglycemia per whatever hospital policy that you're working at. The book states that the glucose checks are recommended within 30 minutes of birth and hourly. These babies are often used to a higher blood sugar and have higher sugar needs due to increased body weight. So when that umbilical cord is cut, that continuous supply of sugar is gone, and hypoglycemia is a problem. So the initial colostrum may not be enough for them to maintain a normal blood sugar, and often supplementation with formula or that glucose gel is probably going to need to happen. Getting that baby to the breast early and often is very, very important with these LGA babies. If they're going to bottle feed, getting that regular feeding schedule is important to educate the parents on. Intake, output, daily weights need to be recorded and evaluate the effectiveness of whatever their nutritional intake is. Finally, these babies are high risk for polycythemia and hyperbilirubin, which is jaundice. This can cause neurological problems if not treated early. So while physically assessing and performing their interventions, one of the most important things you can do for either an SGA or an LGA baby is to educate their parents. Make sure that they understand what their treatments are and the procedures and why they are necessary. They need to be a part of the care, and they become an extension of our assessment team, because our nurses have multiple moms, multiple babies, and if they're noticing something is not right, if their baby's not feeding right, if they're not having good output, they're going to be the first line person to tell the nurse and trigger more thorough assessment from us. So get your parents involved. So now we're going to transition to some more serious conditions in newborns, congenital versus acquired conditions. You're going to get many of these conditions in more detail during your PEDS course, but we're going to do a small introduction and a few specific conditions. Due to advances in medical and nursing care, many babies are surviving these high-risk conditions, which makes them a very vulnerable population as they grow, and we will all see them in some way. Congenital anomalies are structural, functional, or metabolic anomalies that are present at birth. Most congenital anomalies are very complex, and what happens is a gene or multiple genes are impacted by social or environmental factors during organogenesis, which is the origin and development of organs, which occurs very early in pregnancy, and often mom doesn't even know she's pregnant yet. So, what are the actual causes? There could be a single gene disorder, there could be a chromosomal anomaly, there could be a teratogen exposure, or it could be completely sporadic, and we don't actually know what causes it. According to the World Health Organization, 6% occur globally, 2 to 4% occur in the US alone, and it is the primary cause of death in infancy. So the list of most common serious congenital disorders are congenital heart defects, neural tube defects, and Down syndrome. These are all congenital anomalies that are listed here on this picture. But we're not going to go and test you on all of these specific conditions, but please reference your book for pictures or descriptions. Loma Linda sees a lot of these babies because of our level 4 NICU and the OB being an ICU situation. So cleft lip, esophageal atresia, congenital diaphragmatic hernia, gastroschisis, omphalocele, biliary atresia, bladder, extrophy, and open neural tube defects. So I want to talk about one acquired condition that we will all see no matter where we work as a nurse. I've seen multiple patients come in pregnant with these conditions, and I've also seen multiple babies born with these conditions. So congenital heart defects are structural defects that involve the heart, the great vessels, or both, and the defect is present at birth. So these conditions may be known before birth, but often they're discovered in the first few weeks after delivery as the baby's circulation is adapting to the demands of extrauterine life. Because before delivery, they're using mom's circulation. And once we cut that cord and it transitions from fetal circulation to newborn circulation, that's when a lot of these conditions become problematic. So 40,000 babies a year in the US are diagnosed with a congenital heart defect. And they don't always require surgery, but 7,200 of those babies do have critical congenital heart defects, and they're going to have heart surgery within the first year of their life. When you get into your peds course next quarter, you're going to go into detail about these conditions, but I feel it's super important to mention in our course because medical advances have dramatically improved for our screening of these conditions, as well as how we treat them. These patients are now surviving into adulthood and will be seen in all areas. So you'll see them in their peds departments, your ER departments, med-surg, ICU, urgent care, outpatient clinics. So it's important to be aware and prepared. How does a baby end up with a congenital heart defect? Well, during the first 8 weeks of gestation, the fetus has critical organ development, and while the cause of CHD is unknown, the malformations of the heart is usually the result of genetic and environmental forces. As I said earlier, CHD has a range from mild condition to more serious, called a critical congenital heart defects, CCHD. I listed them here, but this is just an FYI. You're gonna get into these conditions later in the program. So why do I feel it's super important for you to hear about this in our course? Well, it's because you're going to be caring for these moms and babies now. You are in clinical helping to assess and screen newborns. Maybe you've even been a part of a delivery or care team for a baby with CHD at this point. At Loma Linda, we actually have the capability of putting our moms on telemetry. So if you have a patient who was born with a congenital heart defect, or they developed something cardiac in their life, they may be on telemetry while they're in labor. So that's why I really wanted to talk about it. The nurse is going to do a head-to-toe assessment after delivery on every baby. So this is a great time for them to note any heart sounds that are abnormal, note the rate and rhythm, additionally any cyanosis. So are they having central cyanosis and it's been a while since they've been delivered? Is there any signs of respiratory distress and they had transitioned but now they're struggling? Are they having difficulty feeding? Because if you have a cardiac condition, that suck and swallow is very, very difficult. Or are they super, super irritable and there's no other reason? These can be early signs that something's going on. Then, at around 24 hours of life, the baby is going to be screened with a very simple pulse ox test that we call the CCHD. I went over it specifically during Module 7, and I put this algorithm on our slide here for what passing is and what is failing on the slide. This is a great screening test that allows us to assess, diagnose, and treat CHD early to improve outcomes for these babies. If a baby fails the CCHD screening, it doesn't automatically mean that they have a heart defect, but it allows our care team to put orders in for them to get an echocardiogram and have a closer look taken. We need to be able to assess and manage these babies by knowing their risk factors and ensuring that there's proper assessment to ensure that healthy and happy family when they go home. Acquired disorders are the other side. It's a result of something that has occurred at or around birth, or a condition that's experienced by the mother during pregnancy. For example, if a mom has an infection like a torch infection that we talked about in Module 5, if they have diabetes or a substance abuse problem. Additional risks can come from conditions associated with labor. So if the mom has had a prolonged rupture of membranes, if there's fetal distress, the 4 H's, so hyperbilirubinemia, hypothermia, hypoglycemia, hypoxia, birth injuries, meconium aspiration. These are all acquired conditions. Professor Payton discussed a lot of those in the previous module, so we're going to now focus on a few other acquired conditions in this section. Our first acquired condition is substance-exposed newborns. So mothers who misuse drugs and substance addiction has dramatically increased in the past few decades to an epidemic proportion. So much so that among kids that are 12 years and older, 14.5% of them are diagnosed with a substance use disorder, which means their mothers use substances while pregnant, and these kids are now suffering from the exposure. Tobacco, alcohol, and illicit drugs are impactful to the mother, the developing fetus, the safety of their labor and delivery, and they have lifelong impacts for the patient and the family unit. Here are some statistics for you to think about. 15.9% of pregnant patients report smoking cigarettes. 8.5% of pregnant patients report drinking alcohol. And 6% of pregnant patients report use of illicit drugs. And those are just the patients that are being honest, which means there are patients we are not capturing in those percentages. The substances that are most used and reported are tobacco, alcohol, cannabis, opioids, and cocaine. So what exactly are we worried about with a substance-exposed newborn? These newborns are at risk for birth defects, poor cognitive outcomes, preterm birth, low birth weight, miscarriage, stillbirth, neonatal death, and sudden unexplained infant death, also known as SIDS. Mothers are at risk depending on the type of substance that's being used. Cocaine and methamphetamines during pregnancy put the patient at risk for developing maternal hypertension and can cause placental abruption. I've actually had that a few times when a patient came in having a severe placental abruption, and it was because they were on methamphetamines. In addition, substance-exposed babies are more likely to suffer from abuse, neglect, and be placed in foster care. So one of the patients I've actually had that I talk about the story frequently is we actually had somebody come in through triage, and she was homeless and had been behind a gas station and was very obviously pregnant and was in distress, and somebody called 911 and they brought her to our facility. And she was a very long time drug user. She had mental illness, and she was probably like 100 pounds, but she was very pregnant. And when we checked her blood pressure, it was, I think, like 200 over 120. And she was so close to seizing, and that baby did not do very well. It was alive, but the baby on the monitor looked really bad. She didn't really care that she was pregnant. She didn't really want the baby, and she ended up being very problematic on the unit for multiple days. She was covered in lice and was physically and verbally abusive to the staff. It was probably one of the wildest experiences I've ever had, and that baby had very, very severe withdrawal from methamphetamines. So our next one is alcohol. So fetal alcohol spectrum disorder, which is called FASD. Alcohol use during pregnancy is currently a fast-growing healthcare challenge in the U.S. Even though the risks of developmental disability and birth defects are widely known, it's the leading cause of preventable disabilities in newborns. Fetal alcohol spectrum disorder, the FASD, is not considered a medical diagnosis, but it is an umbrella term that describes the effects that alcohol has on a newborn and child. 1.5% to 5% of kids in the U.S. fall under one of these three categories of FASD, which ranges from mild to severe. There are abnormal physical attributes, there's growth deficiencies, and central nervous system dysfunction that can result from alcohol exposure. As you can see on this chart here that outlines fetal development, by 8 weeks, the CNS, the heart, arms, legs, eyes, ears, teeth, palate, and their external genitals have all begun developing. Some women may not be aware that they're pregnant until they are 8 weeks along. So it really is advised to avoid any substance use during planning for conception or during pregnancy to ensure a healthy outcome for our fetus. FASD occurs because alcohol in the maternal circulation can cross the placenta and then it circulates through the fetus. Alcohol is a teratogenic substance, and it damages organs and brain cells in anyone who is consuming it. Additionally, it causes hypoxia and alters protein synthesis, which interrupts cell growth and differentiation and directly impacts brain and organ development in the fetus. So, FASD is a spectrum disorder, meaning that the effects on the fetus and newborn will be directly related to the timing of the alcohol consumption during pregnancy. Was it the first 8 weeks? What was the amount that was consumed? Is it 1 glass or a large quantity? And what's the duration of exposure? Was it one occurrence or was it daily use? Unlike other substances, alcohol does not routinely cause a newborn to have symptoms of withdrawal. But if the newborn is having withdrawal symptoms, the nurse would expect to see agitation, hyperactivity, and marked tremors for the first 72 hours of life. Here are a few pictures to visualize what the physical manifestations of FASD look like in a baby and a growing child. So these kids have microcephaly, with their heads being less than 10th percentile. Hypoplastic midface, which includes having small eye openings, narrow set eyes, underdeveloped jaw, short noses, joint and limb defects, altered palmar creases. They also tend to have a low birth weight, so being that SGA baby at birth, and that we talked about at the beginning. And they tend to continue to be less than the 10th percentile during their postnatal growth as well. So these babies just tend to be very small. Here's a video about the risks of drugs and alcohol exposure in a fetus and the work that it takes after delivery to lead a normal life. So go ahead and pause our slide, or pause the video, go to the slides, and view this short video. We're going to move on from alcohol to drugs. So we have neonatal abstinence syndrome, or NAS, which occurs when a non-alcohol-based substance is used during pregnancy and chronic intrauterine exposure occurs. So like with alcohol, the substance then crosses the placenta, but these substances will cause the fetus to become dependent. When delivery occurs, there is an abrupt termination of the substance that's being delivered to the baby. And that results in that newborn having a spectrum of withdrawal symptoms that will now require medical management and extended hospitalization to wean from the substance. So medications that cause this, barbiturates, SSRIs, benzodiazepine, nicotine, caffeine, and opiates, they can all result in a baby having NAS. Examples of these types of medications that are that you may be seeing is if a patient needed sedatives, anticonvulsants, anesthetics, Zoloft, Xanax. This is why it's not ideal for a pregnant patient to have any kind of surgical procedures while pregnant unless it's emergent or absolutely necessary. Women who need medication for seizure disorders or mental health conditions need to be aware of the risks and benefits of stopping medication. And they need to be followed very closely by a doctor so they can be on the lowest dose possible, and also be prepared for the aftermath of a baby that is going to be exposed. But the bigger problem are the women misusing prescription medications or taking illicit drugs in pregnancy. According to the March of Dimes, 1 in 20 women are reporting use of illicit drugs while pregnant. This directly impacts neonatal outcomes, and it causes withdrawal symptoms that can have a lifelong impact on these babies. We all know that opioid use in this country is an epidemic, and it directly impacts our babies. Because opioids are so frequently the substance that are being abused in pregnancy, it led to a more specific type of NAS that they call NOWS. The acronym is Neonatal Opioid Withdrawal Syndrome. Protocols are now being developed specifically targeting opioid withdrawal symptoms in newborns. You can see on this slide all of the different medications that can be consumed and cause this. There are illicit opioids, there are street drugs, and we also have prescription pain medication. There's also medications that aid in the weaning from opioid use disorders. So even if a patient has taken steps to get clean, the medications that aid in weaning them will still cause a dependency in the baby. 7% of pregnant women report using prescription opioids, and 20% of those women report misuse or dependency. This figure is actually from your book. I want to outline what NAS looks like in a baby. First, it's going to impact the CNS, which causes significant tremors, irritability, fussiness, and a shrill, high-pitched cry. Those are probably the most common things that are noticed when caring for these babies. They're very difficult to comfort. They are restless and have difficulty sleeping. Also, some babies may experience seizures in severe withdrawal cases. NAS babies will have temperature instability, tachypnea, apnea, and they will struggle with feeding and weight. These substances cause multi-system instability and take special protocols to assist with safe weaning to ensure the baby can thrive. There's obviously a stigma that follows someone who is using a substance while pregnant, and often the fear around what will happen after delivery, for example, social work, CPS getting involved, it may prevent someone from being honest about their substance use. It's not always obvious that a patient has or is using a substance until their newborn starts showing signs of withdrawal during that 72-hour period after delivery. If the nurse suspects that a patient may be on drugs, a urine drug screen can be sent. Some facilities, a UDS is sent automatically as part of their admission process. Others, they are sent on a case-by-case basis. Ethically, the healthcare team is not allowed to send a UDS without the patient's knowledge or consent unless a patient is incapacitated or it is an emergency. So it's really important to talk with your patient and ensure they're understanding what tests are being done and why. At the end of the day, our goal is not to take their baby away from them, but to provide the best care we can for both them and their baby. Knowing what substance they've used helps us know what the baby's withdrawing from and helps the healthcare team to keep the baby safe. If it is a positive drug screen, if there is a positive drug screen or suspected abuse, the nurse will collect a urine sample from the baby as well by placing a collection bag that has a cotton swab in it in the diaper to send to the lab. I have had multiple times where something was off during my admission assessment and had a drug screen ordered and the result was positive. Had we not known, we would have delayed our treatment for that baby, and it can make the weaning process more difficult. Once the team knows that the baby is positive for a substance, it is time to start screening that baby and ensure the weaning process is started and that the needs of the baby are met. The first screening tool that may be used is the Finnegan Neonatal Abstinence Scoring System. This focuses on 3 categories. So a central nervous system disturbance, metabolic, vasomotor, respiratory disturbance, and GI disturbances. Overall, it looks at 21 common symptoms of withdrawal, and it gives a score between 0 and 62. The higher the score, the more severe the withdrawal. And each facility sets the parameters to determine what the score requires, or what score requires a medical intervention. The next screening tool is Eat, Sleep, Console, and this one focuses on the non-pharmacological care model. Loma Linda and Kaiser use these programs in their facilities as their primary management of NAS. So let's go ahead and look at both of these screening tools. Here is an example of the Finnegan Neonatal Abstinence Screening Tool. Normally, a score of 8 to 12 or greater would trigger the need for pharmaceutical intervention. Many facilities are not using this as their primary tool anymore because it takes a long time to complete. It is subjective to the person doing the screening, and it requires stimulation of the newborn to score some of the areas. These babies are very sensitive to stimulation, and it can cause more problems. So while it's helpful and gives a broad picture of how the baby is doing, it can also be detrimental to the newborn going through their withdrawal. Eat, Sleep, Console is a newer model that changes the focus from symptoms of withdrawal to focusing on the essential functions of the newborn and how we can support those. It's very easy to use compared to the 21 areas of assessment on the Finnegan's tool. There's only 3 things: eating, sleeping, and consoling. This tool focuses on encouraging family-centered care, reducing opioid exposure, and reducing the length of stay in the hospital. So how do we do that? The nurse is going to be getting the parents involved and working to get this baby breastfeeding well. Keep baby skin to skin as much as possible. If they're not skin to skin, getting them swaddled for comfort. Keep that baby with their parents for bonding, and keep the environment quiet and very non-stimulating. The photo on this screen is actually the algorithm that Loma Linda is currently using to manage their ESC policy. Each facility is going to have their own. I looked at Kaiser's and Loma Linda's, and they're very similar, but always refer to your specific facility that you're working in. The first line of treatment for NAS and NOWS babies is non-pharmacologic, with the goal of helping the newborn to self-organize, support their neuromaturation, and promote connection between the parents and their baby. These babies may need to be held a lot. They're going to want to feed frequently at the breast or the bottle, and they may need a pacifier for non-nutritive sucking. And it would be important to cluster all your cares as much as possible while keeping the environment quiet and non-stimulating. Now, if the non-pharmacological methods are not working and this baby is not weaning without support, the management will need to shift to pharmacologic interventions. The ESC protocol will continue, and then the nurse will need to do a Finnegan score to dictate what medications need to be administered. Our goal and focus for these babies is to support their nutritional needs because they often struggle with excessive sucking, poor feeding, and regurgitation. So they're spitting up all the time. They also have difficulty gaining weight. They lose weight super easily and have diarrhea. The team should focus on preventing complications like skin breakdown because with low birth weight, diarrhea, dehydration, and their irritability, skin breakdown is very common in these babies. Finally, get the parents bonding with their baby. This is not just a crisis, but it's an opportunity for us to help these parents to navigate a difficult time in their lives and provide the support they need, the resources available, and encourage healthy behaviors for them to move forward. Withdrawal management can last for up to 6 months, depending on the case. So this is a long journey and can be lifelong for the baby and the family. Here are 2 short videos to show you what seizure activity looks like in a newborn and what the tremors look like. Please pause our video here and go to the slides to play each of these. Here is another video that was done by the Washington Post to follow a mother and her baby through navigating NOWS. It is not our place to judge these patients, but to support them and to try to keep these families together through support and resources. So go ahead and pause the video again, watch this in the slides. Let's go ahead and move on to another newborn complication, which is neonatal sepsis. Neonatal sepsis is an infection of the bloodstream that occurs within 28 days of life due to the newborn having an immature immune system and having exposure to a microorganism that causes an infection. While in utero, the fetus will gain some antibodies as well as from breast milk after delivery, but overall the immune system is not always prepared and sepsis can occur. Sepsis is a major cause of illness and death during the neonatal period because of the immature immune system and newborns having a poorly developed skin barrier. 0.5% of 1,000 births in the US will develop sepsis, and it has a 3% mortality rate among those who have it. If the baby is preterm, they will be a much higher risk compared to a full-term infant. So how does neonatal sepsis occur? Well, a bacteria, virus, fungus, or other toxin overcomes the newborn's defenses and causes an infection in the blood or tissue. Newborn infections are grouped into 3 different classes. First, if the baby is born and shows signs of infection within the first 3 days, it is considered a congenital infection. What might cause a congenital sepsis infection? Do you remember Module 5 when we talked about torch infections? Maternal infections in pregnancy can be significant to the baby even after delivery. Next, the most common is the early onset infection that occurs after day 3 of life, but before 7 days of life. This is considered a vertical transmission that occurs shortly before or during birth, and the microorganism comes from the birthing parent. Finally, late onset infections occur after 7 days of life, but before 28 days, and they are considered a horizontal transmission infection, and it's caused by a bacteria from the hospital environment. Early onset neonatal sepsis infection is the most common cause of newborn infections, and it occurs from a transplacental infection where the bacteria ascends from the cervix into the uterus during labor, or when the baby encounters a colonization of the organism in the birth canal. Again, back to Module 5, we discussed torch infections. One of those is group beta strep, or GBS. This is why it's so important to treat GBS positive patients during their labor with ampicillin or penicillin. It can have a profound impact on the health of the newborn. You can see here other microorganisms that can cause newborn infections and potentially sepsis if untreated. Signs and symptoms of neonatal sepsis are wide-ranging, and often the observation is simply the newborn doesn't look right. And that is the first thing that the nurse or the parents notice. This makes diagnosis very challenging because the signs and symptoms are usually nonspecific and can be overlooked. Many of the signs and symptoms can be confused with other newborn conditions, but as the condition worsens, late signs like seizure activity or hypotension can occur. The goal would be to identify the infection and intervene early. Education to the parents of high-risk newborns before discharge is imperative and can be life-saving. The goal of the nurse is going to be to know the risk factors for newborn infection and try and identify the infection early to ensure prompt treatment, because that is the only way to reduce the morbidity and mortality for these newborns. When caring for a patient, risk factors that should raise a red flag for a possible acute onset neonatal sepsis infection would be a mother who's GBS positive. The nurse should be asking lots of questions. Was this patient treated with antibiotics before her water broke? Has it been greater than 4 hours since her loading dose of antibiotics? Have the patient's membranes been ruptured greater than 18 hours, leaving room for vertical transmission of bacteria either naturally or as a provider does a vaginal exam, bringing the fingers into the vagina and up into the cervix? Has this patient had any interpartum fevers? Was she diagnosed with chorioamnionitis in labor? Is this baby premature? And is the baby low birth weight? These are high risk factors and often prompt a conversation with the pediatrician after delivery to determine if further evaluation is needed. Now, if there is a suspected infection, the nurse would expect to draw labs to assess for anemia, leukocytosis, and leukopenia. Elevated CRP levels would indicate inflammation, and blood, urine, and CSF cultures would help to identify the location and type of infection that's present. Chest x-rays and abdominal x-rays would be ordered to see if there's any infectious process occurring. And if there are any cultures that come back positive, that would confirm that newborn has an infection. Our number one goal with managing neonatal sepsis is to improve the newborn's chances of survival. We do that by ensuring that we have early recognition and diagnosis of newborn infections. Once we know there is an infection, the provider will order broad-spectrum antibiotics while the cultures are still pending. Once that specific organism is known, the antibiotics are going to be changed to a more narrow spectrum and ensure that organism is treated properly. Once the patient's on antibiotics, the support of the newborn's systems needs to be top priority to prevent any long-term damage from occurring. So, management of our environment to keep the baby comfortable, keep baby hydrated, that's all going to help the baby heal. Next, there's going to be many healthcare providers and family members around that baby. So we need to ensure a sepsis is maintained for all encounters and procedures with that baby. He or she is already fighting one organism, so we don't need to give them another one to battle. Finally, the family needs to be in continuous education on what is happening, what's the treatment plan, and support the bonding process still as much as possible, because that will help healing. Perinatal infections have severe consequences to those who are affected. Because of this, it is the role of the nurse to ensure there is awareness and understanding about the risk of newborn infections. How do they happen? What are the risk factors? How can we do our part to prevent them? A huge part is education. For example, when someone comes into labor and delivery, she's GBS positive, her water is broken, she's 36 weeks pregnant, that baby is high risk for having a newborn infection. It is the job of the nurse to educate the patient and their family about the potential risks and what they can do and plan for during their labor to limit the risk of a vertical transmission infection. You want to be changing soiled chucks pads regularly. We're going to limit their vaginal exams. Maybe we're going to augment their labor with Pitocin so we can speed it up. And we want to limit invasive procedures like placing any internal monitors. So first, being aware of the risks, and second, educating the patient are essential to lowering the risk of infection. This is just one scenario that could play out. But what should be the focus of the nurse is primary disease prevention, because that is our key. I always tell my patients on admission that my goal is a healthy mom, a healthy baby, and a happy family that gets discharged home all together. We made it! So this is the end of Module 9. Please feel free to reach out with any questions about these topics, and happy studying!